It will be my pleasure to introduce Jan Kiilgaard from Denmark in Copenhagen. And Jan will talk on can survival of uveal melanomas be improved? Very important issue.
Dear colleagues, dear organizers, thank you for inviting me to this SOE webinar on uveal melanoma. My name is Jens Kiilgaard. I'm a professor at the Copenhagen University and Copenhagen University Hospital, Rigshospitalet. Today's subject is, can survival of uveal melanoma be improved? Several large cohort studies have shown that the death from disease-specific disease in uveal melanoma is about 50% after 15 to 20 years after diagnosis, indicating that 1 out of 2 patients with uveal melanoma will eventually develop this disseminated disease, primarily involving the liver. In contrast to cutaneous melanoma, there are no good treatment options for disseminated uveal melanoma, but there are encouraging studies published in New England Journal of Medicine regarding tebentafusp. The poor outcome for uveal melanoma is probably due to the low mutational burden shown here on the right panel, where we only have 2 mutations, 1 driver and 1 initiator, in contrast to the left panel for cutaneous melanoma, where each dot represents a mutation in the tumor. Bill Harper's group from Miami investigated 139 primary uveal melanomas and found that the mutational burden was very low. They also identified that the mutational changes happened exclusively in the tumors, and they were able to identify 2 to 3 groups, 1 low, intermediate, and high risk group for developing metastatic disease. This led the group to propose the hypothesis that these early exclusive mutational changes defined the fate of the patient regarding no matter what treatment was given to the patient. The problem with the uveal melanoma metastasis is that they can occur very early, but they can also occur very late, up to 42 years after the primary diagnosis. And this concurs very poorly with a hypothesis of a punctual evolution of metastatic disease. We therefore wanted to investigate a bit more about the metastatic evolution, and we set out to analyze matches, pairs of primary melanomas and their liver metastases. But before we go into this, I'd like to talk a little about mutant allele frequency. Imagine a tumor arising from one mutation, undergoing different mutations are analyzed by a biopsy. We can now take the different population of genetic subpopulations and identify the number of new mutations. Whereas the first mutation will be present in all the cells, the next mutation will only be in a fraction of the cells, and the last mutation will be in the smallest fraction of cells. It is now possible from the different fractions of mutations to make a graph of the evolution of the tumor. Shown here where we have mutation 1 giving rise to the primary tumor and a new mutation 2 giving rise to metastasis. As all cells have 2 alleles, we will find the mutation in 50% of the alleles in the primary, but also in 50% of the metastatic cells. Whereas mutation 2 will only be found in a fraction of the primary melanoma, but you will see it in 50% of all the alleles in the metastasis. Now imagine you have a third mutation rising in the metastasis. This mutation will only be seen in the metastasis and not in the primary melanoma. Now let's go back to the patients we analyzed, where we could show a mutational map. And from this map, it was possible to draw a phylogenetic tree, where we see mutations unique for the primary and unique for the liver metastasis, indicating that this took place after the metastatic seeding. But we also see genetic changes that are common for both the liver metastasis and primary, indicating that this took place before the metastatic seeding. If we now look at the total cohort, we see that the metastatic spread often took place before the diagnosis of the primary tumor. We also see that the changes of chromosomal abnormalities increases with the development of metastases, leading to the hypothesis that the development of uveal melanoma metastasis is a gradual situation where we have the melanocyte evolving into the precursor lesion, evolving into the primary tumor. But already very early, we do see that some of the cells are giving rise to micrometastasis seeding. But as the tumor evolves, you have more and more metastasis seeding, and eventually you have macrometastasis developing. This hypothesis was confirmed by Bill Harper's group, which also showed that evolution of metastasis happens in a gradual way. We know from our cohort studies that patients with normal chromosomes have a better survival than patients with just loss of monosomy, loss of chromosome 3 or gain of chromosome 8q. And patients with a combined monosomy 3 and 8q gain have a very poor prognosis. We also know that smaller tumors have a smaller fraction of abnormal chromosomes compared to larger tumors, reflecting also that smaller stages of ATCC tumors has a lower fraction of abnormal chromosomes compared to larger stages. We now went back and investigated the survival and incidence in the Danish cohort over a 70-year period. And due to large changes in both society, but also in the age distribution of Danish patients, we used the age period cohort model rather than the age-adjusted incidence rate, because the health status in the society also changed dramatically during these 70 years observation period. And interestingly, we saw that the survival of patients with small tumors actually improved during the period, whereas patients with large tumors had basically the same survival over the whole period. We also found that the incidence of uveal melanoma is rising in Denmark, and we now have about 12 per million persons. And this rise is primarily seen in small melanoma patients. Just to ensure critics that we are not treating a nevi, we here have a plot of all the tumor heights for patients treated, and we see that there is a trend towards a lower height, but this was not statistically significant. What has happened is there's been more centralized treatment of tumors in Denmark, so it's now only treated in 2 major centers. The problem with epidemiological studies is that you are following a cohort, and at the end of the study, the patient is either alive or dead. And from these data, you can draw a Kaplan-Meier curve. The problem is sometimes you include patients that are lost to follow up, either because they immigrate or because they die from a different disease or cancer. And in these cases, you need to do a analysis taking in care of competing risk, because you cannot die from disease-specific disease if you have died from a different reason. But the biggest problem is the inclusion of patients. So if you start to look for the patients or even initiate a screening program, you find patients earlier, and thereby you are giving them a longer observation period and a false improved survival rate, also called a lead time bias. If you want to take this into account, you need to look for the relative survival, and we also did this in the Danish cohort. Shown here on 4 panels, where the blue line represents the background survival and the colored graph shows the individual tumor sizes and survival. And what you see is in the 2 later periods from 1981 to 2017, the survival of small melanomas is actually identical to the background population, and you also have improvement of the T2 tumors compared to the 2 earlier time periods. Whereas the larger tumors has the same survival rate in all 4 periods. In addition to death from disease-specific disease, we also find that the uveal melanoma patients has an increased risk of developing a new primary cancer. And in panel A, you see the black curve representing the risk of cancer in the background population, and you see the red curve for the uveal melanoma patients, and you see that the two curves cross over, indicating that in the first part, the uveal melanoma patient actually has a higher risk of developing new cancer compared to the background population. For the sub-analysis done in panel C, you see that patients with small uveal melanoma actually survives and are able to have a lifelong increased risk of a new cancer, whereas the patients with higher tumors actually die from the disease and therefore cannot develop a new cancer. In summary, the evolution of uveal melanoma is gradual and the metastatic proclivity of a given tumor is not set in stone, indicating that earlier detection and treatment of uveal melanoma is beneficial for the patient. For larger tumors, dissemination of disease has probably already been taken care of at the time of diagnosis. We stress that uveal melanoma patients has a lifelong elevated risk of developing other primary cancer, and we will suggest that metastatic disease is validated by histopathology in order to not overlook a cancer which could have been treated with chemotherapy. Thank you for your attention.
Thank you, Jens. Fantastic presentation. Just to put you on the spot again, are you in the early treatment safe life camp or in the other one with the horses bolted?
No, I definitely agree with Romana in her talk that we need to treat early. We need to find the monosomy 3 tumors before they get the 8q gain. And it seems like in metastatic disease, it's the 8q gain which is really the major player here.
And when we talk to the patients, they are asymptomatic. It's close to the fovea. We know we're going to harm their vision, and they tell me, "What's the percentage? What's the gain? How many lives do you save if you treat 10 patients like me?" Do you have any idea based on your data?
That's a really, really good question. So the short answer is no, I don't.
Yeah.
But the problem is that we do see now we have been taking biopsies for more than 12 years, and we have these high-risk patients we follow each year, and we have some with small monosomy 3 tumors which apparently do not die. The problem is the very late metastasis. So if you ask if you're going to save life, we don't know, but it's my clearly belief, and this is something I can do in church, I know that, but it is my belief that that we will definitely prolong life if we try to get them before they actively have these 8q gains. So I think the 8q gain is the major player.
And so the question is, we do all these biopsies, and let's say we have a completely normal chromosome 3 and 8, and it's close to the fovea. Would you then perhaps base your recommendation for treatment on that result, or not really? Would you say it can still go in the other way?
Yeah, so I have the luxury of getting a completely normal chromosome for very posterior tumors. We don't see that. I don't know why we always have monosomy 3 in our posterior located tumors, or maybe we are too late to biopsy. Maybe we need to do more biopsies. It is also a question. But if you have a completely normal chromosome and you have all the other risk factors, no, I would still treat them because it will probably just a matter of time before they have their changes.
And there was a comment about tebentafusp in the chat, licensed obviously today, as we learned in the chat. Do you have any comments on that? Is there any link to your biopsy results? Can you filter out patients that may benefit from it?
Yes, we will start looking for HLA A2/0 subtypes. So we don't know right now how many of our patients actually have that subtype. But tebentafusp is only prolonging life. It's not really saving lives, but that's still a huge, gigantic step towards a better treatment of these patients, which basically always have been considered like being lost life when you have a melanoma. If you die from it, you die from it. and that was the end of the story. But it seems now we can actually change that, and I think that's great news.
And for the audience that hasn't heard from it, can you in 2 sentences say what it is and how it works and what it does?
Yeah, so it's a protein that binds to the GP100 on the T cells, and it also binds on a receptor on the melanoma cells. And what it basically does, it makes the immune system attack the cells, and then it doesn't hide from the immune system, which is a major problem with our tumor cells, is that the immune system seems to be doesn't care. They don't see the cells. So the GP100 molecule can be used to attack these cells. So it's an elegant way to do chemotherapy in these patients.
And do you have an idea how many patients benefit at the moment? I mean, it's a starting point, isn't it? Yeah.
For the article published in New England, it seems like it's about a third to a half of the patients which could benefit from this treatment. But I don't know the data for this. It needs to have this special allele subtype.
Mm-hmm. Thank you, Nikos. Do you have any questions?
I would like to ask you about surveillance. Do you make a difference on surveillance, watching the patients to develop metastasis, stratifying them in high or low risk patients?
Yes. In Denmark, we only have a certain amount for healthcare. Everything is free, so we need to be very careful to choose the patients that needs the follow-up. And we have now actually put all the high-risk patients into ultrasound surveillance, and all the low-risk have no surveillance. And we have lost one patient in the low-risk group due to this strategy. That's unfortunately, but it seems like all the other biopsies gave us the correct answer for dividing them into a high and low-risk group. So we've continued to do that because, yeah, it's very nice to tell the patients you don't have a high risk, you don't are at risk from dying from this. We got the disease in good time. And for the high risk patients, they actually change their life. So when they get the knowledge of having a high risk profile, they start living their life in a different way. And basically, they actually do appreciate the knowledge we give them. And we also say to them, this is not a death sentence, because only half of the high-risk patient will actually eventually die from metastasis. So it's only the last half, or 40%, which will die from the metastasis. Yep.
Thank you very much.